Welcome to the Workplace Minute, powered by H3HR Advisors and sponsored by WorkHuman. Thanks for joining me for your quick update on what's important in the world of work. My name is Steve Boese. Healthcare costs are preparing to take another enormous bite out of employer budgets and employee paychecks in 2027. Let's dive into the details. According to a new analysis from Aon, the cost of employer-sponsored healthcare in the United States is projected to rise 9% next year, before employers make plan changes or introduce additional cost management programs. That increase would push the average cost above $19,000 per employee and extend one of the most severe periods of healthcare inflation employers have experienced in decades. Now, this is not a single bad year. Aon says 2027 will be the fourth consecutive year in which employer healthcare cost increases have approached double digits. Its data shows that the annual increase in employer cost have more than doubled from 3.5% in 2022 to 8.8% in 2026. Aon's projection is based on its Health Values Initiative database, which includes more than 1,100 U.S. employers, 7.9 million employees, and approximately $135 billion in healthcare spend. This is a substantial data set, and the 9.5% projection assumes employers maintain their current plans without making additional changes to benefits or care management programs. Now, employers will undoubtedly attempt to reduce these increases. They'll renegotiate contracts, adjust networks, modify formularies, introduce new utilization controls, and maybe even redesign plans. Even after those efforts, however, employers and employees are likely to experience another year of significant cost growth. Aon estimates that the total cost of an employer health plan increased 8.3% in 2026, from about $16,200 to $17,500 per employee, and the employer portion increased 8.8% to about $14,400. Employers now pay approximately 82% of the total plan costs, which shows that many organizations have continued to absorb much of the increases rather than passing all of it directly to workers. But employees are certainly feeling the pressure as well. Aon estimates that the average employee will spend about $5,300 on healthcare in 2026. That includes about $3,100 in premiums deducted from their paychecks and another $2,200 in deductibles, co-payments, and other out-of-pocket expenses. That total employee burden increased about 8% in 1 year. Most concerning, employee out-of-pocket expenses increased 10%. That means workers are paying more for coverage and then paying considerably more when they actually use healthcare services. And Aon's projections are not outliers. PwC's separate behind-the-numbers analyses projects a 9% increase in medical costs for the commercial group market in 2027, and that's the highest projected increase in 17 years. And a separate WTW employer survey reproduced an even higher estimate, with employers anticipating an 11.1% increase in healthcare costs in 2027. So why are costs rising so quickly? Aon organizes the problem around three factors: price, utilization, and mix. Price is the amount paid for a medical service or treatment. Hospital and provider consolidation can give health systems greater negotiating power, leading to higher reimbursement rates. The same scan, surgery, or office visit can simply cost more from 1 year to the next. Utilization refers to how much care people use. Aon is seeing more outpatient services, diagnostic testing, hospital care, prescriptions, and treatment for chronic conditions. Behavioral health utilization also continues to grow, according to PwC. Some of this represents people receiving needed care that was previously delayed or unavailable, but it still adds to total plan spending. And mix describes the types of care and treatments being used. More patients are receiving specialty medications, biologic drugs, and services delivered in expensive settings. Aon says that historically price accounted for about 75% of healthcare cost growth. Today, utilization and mix account for about 60% of the growth. Now that shift's important. Employers are no longer dealing with primarily higher prices for the same package of care. They're paying for more care, more complex care, and a rapidly expanding collection of more expensive treatments. Prescription drugs give us one of the clearest examples. The use of specialty medications continues to grow, and Aon reports that utilization of specialty drugs is increasing at approximately 14%. Across Aon's employer clients, Use of anti-obesity GLP-1 medications increased 75% in 2025. And GLP-1 use could expand further as these medications receive additional approvals for conditions including cardiovascular disease, sleep apnea, and chronic kidney disease, and as new oral versions broaden access. Employers therefore face an extremely difficult question. How do they provide access to treatments that may improve health outcomes while keeping the benefits affordable for the entire workforce? There are other emerging cost pressures. Both Aon and PwC point to the use of artificial intelligence by healthcare providers to produce more detailed clinical documentation and coding. Better documentation can improve the accuracy of medical records, and it can also help providers capture more revenue and generate higher bill charges. For HR and benefits leaders finalizing their 2027 plans, the first challenge is affordability. Every additional dollar charged to employees through premiums, deductibles, or copayments has a disproportionate impact on lower-paid workers and people managing chronic health conditions. A plan may remain technically available while becoming practically unusable because employees can't afford to seek care. The second challenge is deciding where to control utilization without creating harmful barriers. Prior authorization, narrower networks, higher cost sharing, and more restrictive drug formularies can reduce short-term spending. They can also cause employees to postpone preventative care, abandon medications, or struggle to obtain appropriate treatment. Cost control and employee health can't be treated as separate questions. The third challenge is pharmacy governance. Employers need a clear policy for GLP-1 medications, specialty drugs, biosimilars, and other high-cost therapies. That policy should define clinical eligibility, prior authorization, ongoing participation requirements, and how outcomes will be measured. Simply approving or excluding an entire class of treatments is becoming increasingly difficult to justify. The next challenge is vendor accountability. Employers have accumulated carriers, pharmacy benefit managers, navigation platforms, condition management programs, virtual care providers, and other point solutions. Every vendor promises better outcomes and lower costs. Benefit leaders need evidence that these programs are reducing total cost, improving access, or producing measurable health improvements. Engagement and usage statistics alone are not enough. And finally, benefits leaders need to communicate honestly. Employees should understand what is changing, what they will pay, where they can receive lower cost care, and why certain restrictions exist. A plan redesign that saves money on paper can fall apart if employees can't navigate it. Those are the decisions employers have to make for 2027. Yet there is a larger truth we should not continue to avoid. To me, it's become increasingly clear that American employers should not be the ones responsible for operating the nation's health insurance system. A manufacturer should manufacture products. A retailer should serve customers. A tech company should build technology. None of these organizations exist to do things like negotiate hospital prices, evaluate oncology networks, determine access to obesity medication, audit pharmacy rebates, or decide how much an employee should pay for a medical procedure. Yet American companies have been assigned precisely those responsibilities. HR and benefits professionals spend enormous amounts of time, money, and organizational capacity attempting to manage a healthcare market they simply can't control. And as we covered recently on the Workplace Minute, one company, Bank of America, now spends $250 million annually just on GLP-1 drugs for their covered employees. No comparable advanced economy in the world relies on the employment relationship as heavily as the United States does to determine access to health insurance. Other countries use different combinations of public programs, regulated insurers, and supplemental employer benefits, yet they've generally established health coverage as part of their national social infrastructure rather than making it primarily dependent on where someone works. And the American approach can't be defended by superior performance and outcomes. According to the Commonwealth Fund, the United States spent approximately 18% of its gross domestic product on healthcare in 2024, nearly twice the OECD average. OECD data shows U.S. spending at approximately $15,000 per person, compared with an OECD average of about $6,000. Now, despite that spending, U.S. life expectancy is 2.7 years below the OECD average. Preventable mortality is substantially higher. Treatable mortality is higher. The United States still has tens of millions of uninsured people, while nearly every other advanced country provides coverage to all its residents. We spend far more. We burden employers with work they were never designed to perform. We make workers afraid to change their jobs or lose employment because their family's health insurance is attached to that job. We force HR leaders to choose each year between increasing business costs and reducing employee affordability. And after all that, we still produce worse health outcomes than our peers. A 9.5% cost increase in 2027 is not simply another benefits planning challenge. It's another warning and signal that the structure itself is failing. Employers can manage around the edges. They can improve networks, negotiate contracts, evaluate vendors, and design more thoughtful benefits. But they can't solve the fundamental problem. The United States continues to ask employers to hold together a fragmented, extraordinarily expensive, and underperforming health insurance system. That arrangement is irrational, inefficient, and increasingly unsustainable. At some point, we will have to stop asking how employers can absorb the next 10% increase and begin asking why they are still expected to run the health insurance system at all. That's it for the show today. Thank you for listening. We'll see you next time. And a big thank you to WorkHuman for supporting the Workplace Minute. Be sure to subscribe to the HR Happy Hour Network on YouTube or wherever you get your podcasts. I'm Steve Boese, and this has been the Workplace Minute from H3 HR Advisors.